I wish to thank the organizers of the BMJ webinar series, especially the one that I've been asked to moderate, and that is the Primary Care Rheumatology. Thank you, Simi, and thank you, BMJ, for that. I welcome my colleague panelists, Professor Debashish Danda and Dr. Syed Atiqul Haq from Bangladesh, old and very dear friends of ours and prominent and famous rheumatologists in their own field. I have been asked, being a moderator, to introduce the subject of primary care in rheumatology. You will be surprised to know that I know absolutely nothing about primary care. I've never been trained in primary care, spent my whole life in a teaching, research, and education, All India Institute of Medical Sciences, New Delhi. And yet, now that I am in practice and while at the All India Institute, I have been seeing large number of patients with musculoskeletal and rheumatic musculoskeletal diseases in my practice, as well as during my days in the All India Institute. And therefore, I'm aware of the problems that these patients face, and then indirectly, their problems are then faced by us who intend to provide them health care. The main issue that we face is of numbers. All the countries in the Southeast Asian area, and I can at least talk about India that I know much better than other countries, the population of 1.4 billion and how many rheumatologists who are trained in the field are available, with difficulty probably we will be able to count about 1,000 of them. So there is a vast lacunae in the available expertise and the number of patients seeking that expertise. No wonder we will not be able to cater for them. And that's where we need our colleagues who are working in the community to help us in at least telling the patient, correctly classifying them, and telling who needs special care and who can be handled at the primary care level. I think that is the aim of what I understand of these webinars, to tell our colleagues practicing in the community to understand the diseases that belong to this field of musculoskeletal and rheumatic diseases. While many patients may have many types of complaints, but all of them actually are not in this field that we are discussing. They may have complaints which the patients feel belong to this area. And occasionally these doctors who are working in the community have the misconception that such and such either laboratory finding or a complaint related to patient's body is all rheumatology. And I will then finish off in next 2 minutes giving one or two major examples. The patient goes and says that I have knee pain. The patient's age is above 60 years of age, has been sitting cross-legged, has been sitting on the floor all throughout life, has been spoiling the cartilage of the knee throughout his life or her life, and now has gained weight. And this, a doctor in the community will feel is some type of arthritis, and promptly they go for tests. And that is the main issue. They go and get all kind of tests under pressure from the laboratories which are proliferating all over India, even in Mofussil towns as well. And these doctors then feel that getting the test done is the panacea for diagnosis of everything. And as everyone will know, with a pre-test probability of next to zero, they will get these tests done and the reports will come positive and the patients will be misdiagnosed and then rushed to a very highly specialized center or department of musculoskeletal diseases. And that department will be overburdened with such patients who can be simply treated at the community level with simple patient education, how to use their knee, how to reduce their weight, how to go for physiotherapy. Then comes all these immunological tests and their proliferation. Again, these primary care or the community doctors feel that laboratory, if it gives a positive result, that means a diagnosis. So, anti-nuclear test positive in, if you do 100 tests in normal people or those who have minor illnesses, 40% is coming positive in low titer. All of them are being sent to us as lupus. And we are now getting flooded with persons who have fibromyalgia, non-specific pains, aches and pains related to aging and osteoarthritis. And they are all being sent to us that the patient has lupus or rheumatoid. Similarly, there is another very major issue that our community doctors can help us. Any pain, they get uric acid done for some reason. I don't understand why and what it is for. As far as I know, uric acid only tells about the metabolic syndrome, that we are obese, we are going to be hypertensive, we will develop diabetes and heart attack. But somehow they feel uric acid causes joint pain. I have never read that except acute joint pain, which occurs in those who are not looking after their health. And gout is not that common in India, at least. Yet all of them are sent as cases of gout, with high numbers of them even put on reducing drugs that reduce serum uric acid level without giving them any education about uric acid and things of that sort. And anybody with 1 in 10 titer of rheumatoid factor has to have rheumatoid arthritis. This is the concept at the community level, and I'm sure my colleagues will try to dispel these misunderstandings in the community. And with that, I will now invite my colleagues to take up from there and teach our colleagues who are working in the community and make them feel at ease with a patient who comes with aches and pains, who is actually having a musculoskeletal disease, and where is it mostly either functional or minor problems that can be handled at the level of community by a physiotherapist, occupational therapist, weight control, lifestyle change, etc. Thank you, and I hope our colleagues will help us in this.
Thank you, sir. Thank you for that introduction. And let's now introduce our next speaker, Dr. Syed Atikul Haq. He's the Chief Consultant, Green Light Center for Rheumatic Care and Research, Green Light Medical College and Hospital, Dhaka, Bangladesh. Over to you, sir.
Okay, thank you very much. I would say respected speaker, expert speaker, Professor Debashish Danda, our great teacher, Professor Anand Malviya, and also the high officials of BMJ India and the audience. I would say that with the advent of with the realization that the benefits of the advances of science are not being percolated to all segments of the society, and with the advent of the concept of equity in rheumatic care, it is also emerging not only in the low and middle income countries, but also in the advanced nations like USA, UK. In UK also, there are MSc courses which are offered, accredited by General Medical Council, and also offered by famous reputed universities like Oxford University. This, for the general practitioner, the GPs are taking 1 year MSc course and being given, I would say accreditation for treating rheumatic patients, not only in the remote areas, but also within the big cities like London. There are many GPs who have got special training and accreditation for, treating rheumatic patients. So actually, this is particularly true for low and middle income countries, and in particular South Asian countries, where we are running under two different types of crises. One is, there is very small number of rheumatologists. The recommended number is 1 for 80,000 people, one rheumatologist for 80,000 people. But in our countries like India, Pakistan, Bangladesh, Nepal, in these countries, there is one rheumatologist for approximately 3 million people. So that is one, one sort of great deficit. And the other one is our undergraduate curriculum don't equip our undergraduate, would-be physicians with enough knowledge or enough competencies for primary rheumatic care. And this is also a fact that we cannot generate thousands of rheumatologists within the next 5 or 10 years. It is quite impossible. But at the same time, we have to ensure that the advances in science and also advances in the best available evidences, we have to cater good quality care to people with rheumatic pain who are coming from distant, remote places, corners of the country, and also who are suffering from poverty. We cannot, leave these patients untreated or neglected. So I think that, we have to equip our general practitioners with the basic competencies for primary rheumatic care. And that's why I consider this great initiative by BMJ India to be a very important one. This will eventually benefit, millions of people, living in the downtrodden segments of our countries. So I congratulate Simi Kaur and others from BMJ India. And this is a very meaningful and time-demanded initiative. And I hope and I wish that this initiative will breed great success and will increase the quality of rheumatic care in our part of the world. With these few words, actually, this is all I can say. And, very shortly, I sincerely apologize that, I have another commitment for which I shall have to leave very soon. I was very much eager to listen to Professor Danda's lecture and also Professor Malavia's lecture. I respect him so much. But in fact, I have another clashing commitment for which I shall have to leave very soon. Possibly, after 2 to 3 minutes, I shall have to leave. And thank you very much.
Thank you so much, sir. It's a pleasure to have you with us. So without further ado, let's welcome our expert speaker, Dr. Debashish Dana. He's the professor and founder of Department of Clinical Immunology and Rheumatology at CMC Vellore. He's the president of EPLAR and chair of ILAR. He's past editor-in-chief for Indian Journal of Rheumatic Diseases and past president of Indian Rheumatology Association. Over to Dr. Debashish Dana.
Let me just share my slides in a minute.
So the slide is not visible.
I've just shared it. It's saying I'm sharing, but it shows screen sharing is paused. I will stop sharing and reshare again.
Yes, sir. Please try again. It's visible now, sir. Thank you.
Is it visible now?
Yes, sir.
Good afternoon, respected Professor Malvia, dear friend Professor Atikul Haq, all the friends, colleagues from several South Asian countries who are attending here. I can see Dr. Binit here and probably Dr. Nighat is here, and all the officials of BMJ India and BMJ UK, Thank you first of all for giving me this opportunity. I'm fully agreeable to Professor Malviya that what is this primary care rheumatology? So this is certainly a concept being lived uh, for our kind of population, where the rheumatic diseases may not always have the luxury of meeting a rheumatologist. But while looking at the literature, I found some here and there some attempts to educate primary care physicians and doctors in the US and UK as early as 70s and 80s, few small publications how to educate them. Truly there are no big kind of publications, so I'll be going most by the data which compels us to think like this. So primary care rheumatology, with what we understood, is caring for patients with rheumatic musculoskeletal diseases when they cannot reach a rheumatologist. It is not a service that replaces rheumatologists. It is not a compromised care. It is a step towards strengthening rheumatology holistically, and also it is a step towards when the primary care doctors can act as a link between the rheumatologist and the patient, thereby probably creating a new form of referral system in our region. Primary care rheumatology is crucial in a country where rheumatologists are rare, are in scarcity. Medical education ignores rheumatic diseases, and non-rheumatologists are uninformed or poorly informed about RMDs. Misinformation and quackery, often glorified, are rampant, and grassroots people seek their care all the time. Patients cannot reach rheumatologists easily, as Professor Malviya said, and I'll be showing a few slides on that also. And above all, the economic impact of the rheumatic diseases on the patients, his family or her family, society, and the state is huge. So primary care doctors will always remain the first contact for RMD patients and possibly many other specialties. We can and therefore should upskill the primary care doctors in basic RMD care. This ensures patient safety by preventing harm by quacks and misinformation. It creates links between patients and rheumatologists as an effective referral system, as I have mentioned. It also will save life and productivity and cost. Who are the primary care doctors then treating RMDs? Any doctor educated in modern medicine, MBBS and above, I would consider them as the primary care doctor who treats rheumatic musculoskeletal diseases. It's also important that their role is appreciated, especially those of the other allied healthcare workers in modern medicine. But as of today, they would remain a comrade to the healthcare worker, the doctors working in the periphery, who are not the primary care doctors for RMD. I'm afraid the predatory elements like quacks and non-evidence based quarters cannot be called as primary care doctors, and a vast majority of RMD patients, although they visit them all the time, at least a few visits, and it is difficult and not desirable to reach out to them at this moment. It is complex, and often they enjoy political patronage. In the background of this, as Professor Malviya has mentioned, Professor Huck has also mentioned that rheumatologists are few, getting appointments are harder. Much of the healthcare is self and out of pocket expenditure. Patients are often victims of irrational and harmful quackery, and the doctors, the primary care doctors, therefore fill in this gap with basic scientific approach, not as a replacement of rheumatologists. So the rheumatology primary care in South Asia therefore enjoys a significant importance here. The musculoskeletal pain, as we know, not only arises from joints but bones, ligament, muscles, tendons, etc. This is from the WHO website, the most current one. It actually mentions these particular diseases among the arthritic conditions, among the bone diseases, osteoporosis, sarcopenia, which often all of us ignore, spine diseases like back pain and neck pain, chronic pain like fibromyalgia, and connective tissue diseases and vasculitic diseases, as they can be life threatening. We have 106 joints, but the number of arthritis are much more. They are multi-system, lifelong, controllable but not curable like diabetes, and outcome is dramatically changed, especially for the inflammatory diseases. And not only not only they control the symptoms, the newer treatment modalities, they also improve quality of life. The non-inflammatory conditions are much more common. As we know, the mechanical and discogenic pathology cause majority of the back and neck pain. Osteoarthritis is the commonest type of arthritis. Soft tissue rheumatism, repetitive strain, chronic pain like fibromyalgia are common. Osteoporosis is a silent epidemic, and benign things like hypermobility are also often missed out, or if they are detected, they often are ill-treated, often hyper or over treated as an arthritic condition. So there are many aspects to the common rheumatic diseases. So these are some of the common inflammatory diseases. We rheumatologists generally tend to get very excited about these things because we find them very easy to treat, and there have been quite a bit of advancements in treatment, and we can do well. Well, altogether they are also not too less. About 2.5% of the population do suffer from all these conditions, autoimmune conditions together. But while looking at the global burden of rheumatic diseases, again the shortage of experts and the South Asian perspective is something which I am going to mention here. This is a relatively older, this thing about 7 years old. The things have become a little different now, but more or less similar. We can actually see that 1/4 of human population living with this musculoskeletal conditions, therefore, now the recent data shows that probably the commonest now. They have surpassed even the mental disorders, and the others after back pain are osteoarthritis, neck pain, rheumatoid, and few other arthropathies. So this is a relatively older, about 7-year-old data, which has again shown the varying proportion of the back pain, neck pain, osteoporosis, osteoarthritis, RA, gout, and other rheumatic musculoskeletal diseases, which include spondyloarthritis, soft tissue rheumatism, and the connective tissue diseases, etc. Uh, what is interesting now compared to 2010 data and 2017 data and 2021, this paper have shown that at the national level, the highest standardized, highest age standardized point prevalence estimates were seen for musculoskeletal diseases for India, Bangladesh, and Nepal. So if you can see this, the purple bar diagram, it is our South Asia. So you can imagine how important it is to pay attention to it. It is as I've shown, the previous data had about 2010 data had India had a much milder color than red, which was the second highest prevalence for rheumatoid arthritis. But if you take all rheumatic diseases together in 2017, we have probably the highest prevalence of rheumatic diseases together. Even the age standardized death rate seems to be higher in the Indian subcontinent. If you go by all age groups and gender wise, the females seems to be having a greater prevalence across the various age groups, and so therefore it is time to reconsider. This was a challenging data from another group who actually says it is much higher. I think in the hospital setting it may be much higher, but when you have a pooled data from across, you can see again that the back pain, neck pain, osteoarthritis are much more common, whereas rheumatoid is only about 1.3%. Uh, we look at the healthy life expectancy and the early death and disability. We are somewhere midway placed, but I think we have a long way to go compared to the Western world and other developed nations. And much of it is contributed by musculoskeletal diseases. So you can imagine the relevance of RMDs in South Asia. So there seemed to be an urban-rural divide in the population service of RMDs. This was a study by Dr. Arvind Chopra many years back, and he showed that the musculoskeletal diseases prevalence is much higher than cardiovascular, hypertension, diabetes, abdominal tuberculosis, cancers, and skin diseases quite high up. And he also did a rural population. It was almost similar, except the soft tissue rheumatism was little higher in the rural population. There was also elegant data both from rural and urban by the COPCOD WHO ILR study, and it had actually looked at comparison of various nations. Interestingly, the India, Bangladesh probably has a somewhat similar data compared to the other nations, so we share obviously socio-culturally similar geo-ethnic population. In terms of musculoskeletal diseases, we are more or less similar with a minimal differences. In the urban population too, there seem to be almost similar, except for a few things which are here and there marginally different. This was Professor V.R. Joshi's study from villages. Again, he has shown that widespread musculoskeletal pain, back pain, the same pattern which was shown by the global burden studies are more common, and he showed the various types of pain which are more common, and back pain again seem to be most common. This is also interesting study from Pakistan, almost similar kind of a prevalence of various musculoskeletal pain than what we saw so far in Pune and Bangladesh and the other studies. So the combined data from various Indian study was pooled. There was a large number of patients pooled data, again osteoarthritis of all kinds and non-specific musculoskeletal pain, mostly the soft tissue rheumatism, seem to be much higher up compared to inflammatory arthropathies, etc. Now, what is the manpower of rheumatic diseases? This is courtesy our colleague Professor Nighat from Pakistan, who had manually worked out, as Professor Haq has said, that WHO recommends 1 in 80,000 rheumatologists, but we are nowhere near. We are less than 0.1% across India, Pakistan, Bangladesh, Nepal, Sri Lanka, and Bhutan. India is abysmal 0.07% of the required numbers, and we are matching nobody in this regard except for Nigeria. So we have disastrously low number of rheumatologists per population. So there's also an effect on impact of rheumatic diseases on economy. I was fortunate to be a guide to a thesis from Tata Institute of Social Sciences years ago. One of my students from occupational therapy did his PhD there, and he studied the first study of economic burden of rheumatic diseases in India. He had adopted the Government of India data, 10-yearly data, as well as he has adopted Chhattisgarh. He took in urban and rural a large population sample. What was interesting, he calculated the direct and the indirect costs, although psychological cost was difficult to estimate in terms of economy. The true strategies of financial protection, as we know, we can have either health insurance or government health facilities. Whatever said and done, the crux of the question is 85% of the Indians are not covered by any health insurance coverage. So he then looked at what is the out-of-pocket expenditure for the patients. You will be surprised at that 2015, 0.2% of India's GDP amount was the actual amount of out-of-pocket expenditure for rheumatic musculoskeletal diseases in India. 2.2% may sound small, but it is a huge absolute amount in terms of GDP. India does not even spend 5% on education and healthcare together. So 0.2% from patients' pocket is a huge money. What are the outcomes of rheumatic diseases? Well, before saying that, we must say although we have 106 joints, there are much more than 106 arthropathies and other musculoskeletal problems. They are multi-system, they are lifelong, they are controllable but not curable, as I told. Most of us in our mind have this kind of impression of rheumatoid arthritis in hand. But there's also, after saying all the bad news, there's also some good news. There's a changing scenario in arthritis and rheumatism. This, when we were MBBS students, we used to have a spotter of hand like this, and if we could diagnose swan neck and boutonniere, we could pass that spotter. But this doesn't happen overnight. It starts like this, then progresses like this, and then reaches here. And if it nowadays, to get this kind of very bad advanced rheumatoid is very difficult sometimes in teaching institutes where people have been treating rheumatoid much aggressively for the last 15-20 years. So advanced RA is becoming gradually a rarity. Advanced psoriatic arthritis again is a result of neglected treatment, and again going back to where it starts like this with a minimal pain swelling. It's called early rheumatoid arthritis. But look at this hand, absolutely pristine normal hand. This was not normal few months ago. This was after treatment as early RA. So this is the result of treatment in a case of early RA. So what made this dramatic improvement possible? Early diagnosis, early aggressive treatment. There's something called T2T approach using indices of various activity indices which are there now. You can download them in your mobile phone now as apps. I've seen my registrars trainees using something called Rheuma Helper. It gives a whole lot of rheumatic diseases, classification and disease activity criteria, and they even teach the nurses in the OPD ward who can do it in 2 minutes for us, and of course the newer drugs. So all these things have made this magic possible. The same story in ankylosing spondylitis. It starts like this. If not treated or not properly treated, in 36 years this is what happens, starting at the sacroiliac joint, spine, small joints, large joints, and the enthesopathy sites and the eye. But here also there is a good story. After infliximab, this is the Romanosine early angspon. In 3 months of TNF inhibitor, it has become faded, and in 1 year it has almost disappeared. So it start ankylosing spondylitis treatment here. This also should not follow. So time has changed now from RA is diagnosed when swan neck and boutonniere is there, angspon when bamboo spine and X-ray is there, or Sjogren's when a big parotid enlargement is there. Are expensive drug always must? No. This is the most latest study. It has shown after many years of follow-up of older cohorts that if people are treated early with simple synthetic DMARDs, the overall there is a favorable outcome in terms of rheumatoid arthritis disease activity outcome. So it's a good story when the treatment is started early. As I mentioned, T2T and early treatment is more important rather than which drug you use. So here also it shows the structural damage progression is also better when the treatment is started early for synthetic DMARDs. Also for biologics DMARDs, it may be not so much correlating as they have shown here. So simple cheaper drugs can do a good job if the treatment started early and closely monitored. Hence primary care doctors with simple armamentarium can provide basic service before and between visits to a rheumatologist. So not only primary care, even remote care is proven beneficial. The COVID has given us so many lessons, good and bad. One of the good lessons is that the remote care leads to similar or even better results compared to face-to-face treatment concerning efficacy, etc. So and this time I have been going around mission hospitals across India for last few months for to 2.5 does about 16 hospitals. I was wondering that what I'm doing in outpatient, people are coming from 2000 kilometers away to check their ESR, CRP and DAS28 and then find them normal and try to repeat prescription, they go back. Why can't this be done by the local doctor? It will avoid his travel here, it will avoid a lot of unnecessary hassles for him. Now, what are the spectrums of rheumatic diseases? So, spectrum is here very, very huge. As I said, there are more than 100 arthropathies. So, the pattern of arthropathy is important, as I am not going into it detail, but this combinations and permutations decide the various syndromes of arthropathies. However, we have degenerative, we have inflammatory, we have infective, we have metabolic, we have hereditary, all kinds of arthropathies. Common MSK illnesses in community, again as I told, going by the WHO data and otherwise, low back neck pain, osteoarthritis, repetitive strain and soft tissue rheumatism, chronic aches and pains and fibromyalgia, osteoporosis or sarcopenia, and rheumatic manifestations of systemic diseases. Now, common inflammatory arthropathies in community is something which excites most doctor. Even they are not too little either. Rheumatoid up to 1%, SPA 0.5% almost, Sjogren's 0.5%, poorly diagnosed or underdiagnosed. The gout geoethnically variable, in some population they are high too, and the other connective tissue disorder altogether about 0.5%. So it's not a very small prevalence either. There are common musculoskeletal illnesses in children like hypermobility of joints, growing pain and low vitamin D state, often misdiagnosed as rheumatic fever, and they keep on getting penicillin injections just by on ASO titer most unnecessarily, and juvenile idiopathic arthritis. Rheumatic fever is going away, but it's not going away from the mind of our primary care doctors. So this is one which needs to be addressed. So there are also serious rheumatic illnesses or serious systemic illnesses landing up in the rheumatology clinic like malignancies. There are serious infections, complications of connective tissue diseases like lupus, vasculitis, and toxicities of drugs. Now I'll give you a few examples for the audience who are not rheumatologists. The minor rheumatism presently can be presenting sometime as deceptively as serious. First of all, back pain mostly they are mechanical. 95%. Dr. Bookbinder's Cochrane review has shown many years back that most of the acute back pain can be settled in few weeks' time. Well, there are red flags here, but they are only less than 5% of them. So mechanical back pain or discogenic backache is the commonest backache. There are also arthropathies which are not too bad but often are misdiagnosed, like hypermobile joint. Sometimes they get aches and pains. I have seen quite a few hypermobile joints are treated as rheumatoid arthritis. So osteoarthritis is the base of the thumb or the distal interphalangeal joint or the knees or the hip joints, they can be a problem. Now, how do you treat osteoarthritis? I have learned in a lifetime practice that osteoarthritis is not completely untreatable disease. There are a lot of comorbidities which you can treat. You can treat the associated conditions. You can also treat the chronic pain which coexist with osteoarthritis. Osteoporosis is a silent epidemic. If it is not detected and treated, you will only end up getting fractures when they will have symptom. So this is something again the primary care level can have tools to diagnose them and treat them, including Frax tool. This is fibromyalgia. These are not the people with rheumatoid. Sometimes the patients believe they are rheumatoid. Some doctors also get mistaken. Also, they are not nuts. Many a time they are considered as they have depressed patients or they have psychological problem. They can be treated by good education, some exercise program, little medications, and good sleep hygiene, etc. Now, in our country, was all of us call India is the diabetes capital of the world. So these are not uncommon. Seeing this prayer sign, seeing the Tinel sign, Phelan sign because of carpal tunnel, gazing the Dupuytren's contracture or trigger finger. You can chiroarthropathy, you can see it much better here. Hypothyroid present in about 5% of population can produce a whole array of musculoskeletal symptoms. And even hyperthyroid can produce this kind of presentation or acropathy. You can see the periosteal reaction. And you see, it's not so uncommon to look carefully in children. You can get the rickets, and this is pseudo fracture. What the mind doesn't know, eyes cannot see. It will be there in many of your clinics, and the bone may look very white, and this kind of incomplete pseudo fracture is also missed out. Spondyloarthritis, actually speaking, now they're becoming more and more common because of more awareness. So the whole spectrum of spondyloarthritis with their eye symptoms, skin symptoms, enthesopathy, and the lumbar spine restriction, uveitis leading on to synechiae formation, all of them have very good treatment now. So enthesopathies, many doctors have not even heard of. This is something which patients will tell, I have pain here, pain there. You will think it is fibromyalgia. It is actually enthesopathy. If you don't think of it, it will not be picked up. And this can be measured now with various scores. This is another deformity of rheumatoid like, but you look at this. So this is a typical psoriatic sausaging of fingers, which are the nail changes. This is again DIP arthritis, not seen in many other arthropathies, rheumatoid never. So this is dactylitis in a very early stage, sometimes maybe the only feature of psoriasis, and you can see the skin lesions here, so of psoriasis. So this is the very severe gout, and I must tell you that a lot of people in our community keep checking uric acid in a woman of 25 years old. You know, premenopausal women, we hardly ever get gout. Well, on the other hand, I must also confess that in India, we have published that 1/3 of our gout in India and even in China are below the age of 35 years onset. So this is podagra, very severe lesion, advanced tophi can be seen, and very badly deformed gouty arthritis. So this kind of deforming arthritis, whether gout or psoriatic or RA should become rarer and rarer in near future. So this kind of deformities of RA and the nodules hopefully will become less and less likely. And the Sjogren syndrome, if we improve from our mind these images of very dry tongue, all the teeth gone, very big parotid, vasculitis, or the central nervous system or the lung involvement, we will miss out Sjogren till they are very, very aggressive disease. So we have to have a high degree of suspicion. The lupus rashes, although 9 in 10 is a female, I have shown deliberately a male lupus because they tend to be very severe. So these are lesions in a patient of dermatomyositis, which eye and skin, and this is a very bad discoid lupus coalescing multiple discoid lupus rash, very hard pellet painless ulcer in lupus, gangrene because of vasculitis, can be because of antiphospholipid sometime. This is a pseudoclubbing in scleroderma with fingertip stellate scar. This is Raynaud's, which is ignored, can become like this, and skin tightness, puckering of mouth, and Raynaud's you often miss out in our population because of our warm climate and the dark skin. And scleroderma can all kinds of skin changes with contractures and digital ulcers and also all kinds of other complications including the lungs. In children, this is a parvovirus B19 skin rash of slapped cheek appearance, and you can have JIA with polyarticular variety looking like an adult. They can also have systemic JIA rashes. But what is this? This is coming like a polyarticular, very active arthritis in a child, and look at this skin is a bone lesion. This is actually a leukemic arthropathy. So sometimes they can be very deceptive in children. So if we try to look at arthropathies in an isolated way, just in feeling one aspect, just the joint alone, then we will be missing out the full story. So there are also few emergency situations. A bad lupus can come into casualty with neurological or renal, a very bad gangrene or evolving gangrene in scleroderma. If we miss out this Raynaud's phenomenon, we can have this kind of rashes missed out. They can develop very aggressive myositis, life-threatening. A vasculitis gangrene can be missed out and starts like a small mosquito bite-like lesion. You can have this kind of healed vasculitic lesions or active lesions like this. You can also have very aggressive skin lesions in vasculitis like this. They are rare in the community, but they are important that if the time is lost in referring them to a rheumatologist, and if you do not do some kind of basic care, you may lose this patient. So all kinds of vasculitic lesions are possible, wrist drop and foot drop because of mononeuropathy, pulmonary hemorrhage. So whole spectrum of rheumatic musculoskeletal patients can therefore reach a primary care doctors. And GPs must recognize these serious problems early. They treat them in consultation with the rheumatologist. And I must tell you, this will create a new culture of rheumatology practice in our country, which will create a link with the patient and the rheumatologist. The rheumatologist and the doctor in the primary care will improve the rheumatic disease care in this country. As we know, up to 1/3 of human beings suffer from some musculoskeletal symptom or disease in our lifetime. good patient education, sensible pain control, with sensible and safe analgesic practice without much of narcotics, lifestyle modification, basic physiotherapy and occupational exercise, which can be done at the peripheral level, and appropriate consult with the rheumatologist. Inflammatory arthropathies alone account for about 3 to 5%, as I mentioned to you. They should be diagnosed early, and the synthetic DMARDs, which are very cheap, can be used by the peripheral doctor. Very minimum basic laboratory and imaging backup can manage initially. And I must tell you, you are only going to diagnose them if they land up to you. You should signs to refer to rheumatologist immediately. You must know what to do immediately, and you must know how to follow up a rheumatologist follow-up cases when the patient are not able to see a rheumatologist in time. So most cases may need to be therefore handled by the GPs between the visits to a rheumatologist, and familiarity with a rational approach to common diseases and emergency situations are a must. Consultation with the treating rheumatologist is desirable at any stage. So what do we read? What are the basic requirement? The common presentations of common diseases first, basic examples, examination skills like GALS, gait, arm, leg, spine, which you can do in 2 minutes, basic blood investigations and radiography like X-ray, apps which can show you the classification, the disease assessment tools, and the commonly used medications, which you all can have it at any stage. So in summary, primary care doctors must get an overview approach to manage common rheumatic diseases. They will be the best person to handle patients before and between the visits to rheumatologists. Patients can be protected from mismanagement by such a primer course if it is as we are planning today, and the primary care doctors will act as a link between the patients and the rheumatologists, and I think this will create a very good culture of rheumatology care in this country. We should also have our own evidence and our own data driven economic model of care for RMDs in South Asia, which will surely evolve over the years. Primary care doctors can be skilled to manage these patients between and before visits, as I have mentioned to you, and therefore this will be an excellent link between the patients and rheumatologists. So I would like to thank you very much for giving me this opportunity of sharing a bird's eye view of what we have envisioned to be a pioneering and revolutionary program for primary care rheumatology. I'm sure this is there for many other specialty, and we need it much more than others. Thank you very much for patient hearing.
Thank you so much, sir. Thank you so much for giving us an idea about the spectrum of RMDs. What are the common conditions which physicians are likely to see? What are the emergencies, and specifically about the rheumatology in children? So to all the audience, before we take your questions, we would like to announce the official launch of postgraduate certificate course on primary care, rheumatic and musculoskeletal medicine. And to do the honors, we have our senior leadership from BMJ UK and our renowned rheumatologists from Southeast Asia who have contributed immensely in the creation of the course. Let me start first by inviting Dr. Karen Walsh. He is the clinical director at BMJ UK. He is the clinical lead of the medical education and clinical decision support product at BMJ. Over to Dr. Karen.
Thank you very much, Simi, and thanks to everybody for joining us. Kieran Walsh is my name. I'm clinical director at BMJ. I'm a geriatrician turned editor turned educator. Of course, in geriatric medicine, rheumatological and musculoskeletal conditions are common. So I've seen many of the things you're talking about yourself. I should also declare a competing interest that I'm married to a rheumatologist. So I've heard about many of the issues that you speak about in India, and of course they're international issues as well. So I'm going to talk briefly about BMJ's vision and values, our track record in producing educational courses, our processes for producing these courses, and what the new rheumatological and musculoskeletal course will cover. To start with BMJ's vision and values. Our vision of a healthier world drives what we do. By sharing knowledge and expertise, we help improve patient outcomes. It's very straightforward. And we also try to live our values. Our values are evidence-based, patient focus, independence, being people-centered, and also transparent. And many of these values are relevant to this. Of course, we want to and are producing evidence-based content in this field. Content that's independent of influence that might bias it. And we also want to be transparent about any competing interests that we or our contributors or reviewers might have as well. Being strong, trying to producing education in India, Asia. We've been doing this for 7 years. We've produced courses with the team in diabetes, chronic kidney disease, palliative care, acute coronary syndromes. They've been well received. What do I mean when I say they've been well received? Well, they've had a very high usage. We've received a massive amount of positive, qualitative, and quantitative feedback. We've evidence that they've improved knowledge and skills amongst the learners, and also have had impact on their clinical care that they're providing and therefore to their patients. And we have stringent editorial processes. External experts create the content. We get the content independently peer-reviewed by 2 or more experts from national and international contexts. We operate with open peer review, same as the BMJ, all designed to provide the best possible quality. And lastly, the rheumatological and musculoskeletal course itself. It's a 6-month postgraduate course aimed at general physicians, primary care physicians, and non-specialists, which, as we've heard, are so important. It consists of 6 units and 47 modules, from introduction to rheumatology, diagnosis and assessment of rheumatic diseases, management of rheumatic diseases, approach to diagnosis and management of inflammatory arthropathies and connective tissue diseases, and indeed other rheumatological conditions. The format is everything from text, audio to video, state-of-the-art multimedia. And the content is followed by an online evaluation with clinical questions for assessment. We're proud to put it together with our South Asian faculty from India, Pakistan, Nepal, Sri Lanka. Sorry, I want to mention every country: Bangladesh, Thailand, Bhutan, New Zealand, Europe, the US, and of course, the UK. And we're delighted to have Dr. Danda as our course director. And finally, we believe that all of this will make it of great benefit to doctors and their patients and carers, and to primary care physicians and general physicians and non-specialists in India and Asia and around the world. Thank you very much for listening.
Thank you, Karen. Thank you so much. I'm quickly going to, change the pattern the way we have planned. The reason because our strategy director, Anka, she has to leave for a very important meeting. So Anka, over to you for the launch address.
Thank you very much, Simi, and thank you to all the speakers for your really rich content today, really fascinating. My name is Anka Babor. I'm Director of Strategy at BMJ, and I'm going to speak to you today a little bit about who we are as a company, what defines us, and also the importance of India and South Asia as a region for us as a company. Kieran already spoke very eloquently about the fact that we are a mission-driven organization and our vision is for a healthier world. And I'll touch a little bit on this to say that front of mind for us is very much the impact that we are making. And we look at how we can create better evidence, better decisions, and better systems. We are very committed to improving research quality and integrity, patient engagement, faster access to latest research, and we are committing to apply the best evidence in order to achieve the best outcomes for healthcare professionals. How are we achieving our mission? We have our flagship journal, the BMJ, which we have been publishing since 1840, and we are publishing the newest academic research. We also publish education content, and we have clinical decision support tools that help medical professionals make better decisions. We have a great brand and we have a great legacy. And we are also continuously innovating. And what we're talking about today is a fantastic example of how we continue to innovate and how we continue to be forward thinkers as an organization. We are a global company. Our headquarters is in the United Kingdom, but we have a presence which is significant in India, in China, and the US. And our priorities are very much connected to our high growth markets, India being one of them. India is a particularly fascinating market that we really want to grow and nurture, and where we have a fantastic team and we have a great track record. And we're very committed to develop our investments and strategy in order to be able to expand our footprint in India to serve the aims of healthcare professionals. We're already doing a lot here. We're representing journals, clinical decision support, but today is really about the innovation that the team in India are bringing to the South Asian community, but also to the global community, and I'm really proud of this. The Primary Care Rheumatology and Musculoskeletal Medicine course is a great education material, and Kieran already explained a little bit of the structure. And it's very much in line with our values, and I know from Simi and the team how much hard work and how much expertise have really gone into it. So I very much look forward to this course contributing to and benefiting the medical community. Thank you again for your presence here. Thank you to the BMJ team, to Tata 1MG, to all of the speakers, and I wish you a great session.
Thank you, Anka. Thank you so much. It means a lot coming from our senior leadership. So now moving on, let us hear from Dr. Debashish Tanda. He is the course director. He's one person who inspires many, many people. He's never tired, very spontaneous to respond, available at very odd hours in the day. And just like me, he has also invested his 2 years in bringing this course to the reality. So I all the spotlight to him. Over to Dr. Debashish Tanda.
Thank you, Dr. Simi. Thank you, Dr. Walsh, and all the dignitaries of BMJ, Professor Malviya, and everyone present in this webinar. This is actually a great honor for me. I would not have accepted this, and I did not accept for many other offers. It is simply the name BMJ which did not make me think twice. And I had got my decision made very fast, although I knew it is a very tough job. There are skeptics, there are so many other concerns apart from time, which but then I have realized that as a team leader, I could possibly enthuse a lot of people, and I'm very fortunate that we had very enthusiastic rheumatologists, senior rheumatologists across the country, across South Asia, as Dr. Walsh has said, from US, from UK, from Australia, New Zealand, and several other countries. So everybody has, and I did not have a single person whom I had requested whether they could contribute who refused. Everybody had accepted the offer. So this was a wonderful, and Professor Malviya is one of the first to give his module, and we had several I don't know, probably 100 webinars with Dr. Simi, with all aspects of the discussions. Because of the COVID time, it could have been much faster otherwise. Because of the COVID time, it was very difficult to move forward, and so I'm very happy that it is finally is about to see the light of the day. I'm certain that for anything new, there will be always skepticism and doubt, but once it starts and keeps moving, we will see better days ahead, and this will be beneficial to all the general physicians and general practitioners across this region, and we will make sure that we'll address all the feedbacks which you get, and make this is a dynamic process, that it will not remain static in the next batch. I've already inundated with people who are requesting when the course is starting, and many other logistics which I'm forwarding to Dr. Simi. So thank you again for this great honor, and I'm especially thankful for having one hand of blessing of Professor Malviya on my hand, and the other hand of friendship of Professor Huck in the same session. So I think this will be a great experience ahead. If there is any shortcoming, it's all my responsibility. If there's any success, it is all your credit. Thank you very much.
Thank you, sir. Those were very important words for us. Now, last but not the least, Prashant Mishra, Managing Director, India and South Asia. I'd like to invite him on this special occasion of announcements and launching of our course very close to us. Over to Prashant.
Thank you, Simi. I think it's been fascinating to hear what the previous speakers have already said. So, and to be very honest, I had thought of talking about the impact framework. It's just that I didn't speak with or check with Anka. She's already done so. So I'll keep it very, very brief. One of the things which is very spontaneous for me to say here is, having heard Dr. Malviya during the initial talk, and Dr. Debashish building it further, and Professor Huck also kind of giving the same message to all of us. And I think we know, the problem is huge. It's a huge problem. No doubt, diabetes, cardiovascular disorders, they are equally big. But I think today what we are seeing in the society, as a common man, I would say, rheumatology-related ailments, musculoskeletal-related ailments, it's a huge problem. Any family, anywhere you talk, you would heard something around it. I think that's where it becomes so important that we are able to have the right diagnosis. Dr. Malviya, again, I would say, it was such an important message which he gave. It is so crucial to really make the right diagnosis, right? And I think what he then said is where the role of the community comes into play, especially the doctors who serve the community. So the primary care physicians that we have. I mean, it can't be emphasized any further. It's so important, right? So, just to keep it short and sweet, a huge thanks to Dr. Danda. I know you have led from the front, Dr. Danda. And likewise, my sincere thanks and appreciation, acknowledgement to Dr. Malviya for finding time to be with us today. Professor Huck, he was there, he had to leave, but we really appreciate his presence. Likewise, I would want to take this opportunity to say thank you to every contributor, right? Be it our authors, be it our peer reviewers, etc., everyone who's been involved in this journey. I think a big thanks to them. We know that this has happened during the pandemic. We are still not fully out. I think we should all be very proud of the fact that we could really turn around things, despite this being a very, very challenging situation that we've all gone through. Last but not the least, I would also wish to say my sincere thanks to Tata 1mg. They have been our title sponsor for all our webinar series. If I'm not wrong, this is our 5th or 6th one in a row. So grateful to them. And very, very grateful to our colleagues back in the UK, and especially to my team, Dr. Simi, Dr. Gaurav, Sheetal, and others who've been involved. I think this is really a great moment for all of us. And I hope when we launch our next impact report, which you would have heard Chris saying that it's going to be launched around 18th of this month, so which means for the 2023 report, I'll be very pleased to see if we are able to really demonstrate what kind of an impact we have created collectively to shape up this area of medicine. So with these few words, thank you so much to everyone and wishing the course a huge success. Thank you.
Thank you, Prashant. Thank you so much. And now the special announcement. So all the candidates who have enrolled and are watching us today on this webinar, there's a special discount coupon which would be shared with you after this webinar finishes. And this is valid till 12th of July. So get yourself enrolled for this course. It's a wonderful course. There's an entire course detail which is shared on the website, and we'll share the details with you on the mail as well. So now, not holding you for long, and let's start with our next and very important section that is Ask the Expert. I would like to welcome again our senior rheumatologist, Dr. Anand Malviya and Dr. Debashish Tanda, but also we have been joined by Dr. Bineet Vaidya from Nepal. He's consultant in the Department of Rheumatology, National Center for Rheumatic Diseases. Unfortunately, Dr. Nigat Mir Ahmed, who has been immensely involved in the creation of this course, she has to leave. But sincere thanks to her. She's a professor and associated dean, Institute of Rheumatic Diseases, Central Park Medical College, Lahore, Pakistan. So she'll be listening to us post this. And on behalf of BMJ, we'd like to thank you all. So now the spotlight to all our rheumatologists. Over to Dr. Bineet and Dr. Danda, Dr. Anand Malviya. So we have, while we were enrolling the candidates for the webinar, there are questions which were posted. And there are a couple of questions which are very relevant to what we had discussed today. And I'm going to take it with all our subject matter experts. We'll start with our first question, which has come from Dr. Kiran Kumar Chaudhary from Nepal. And he has asked, how do we treat patients with musculoskeletal pain with vague symptoms in rural settings where you do not have sound system for diagnosis? And I'd like to start with Dr. and Professor Anand Malviya. Sir?
This is a very important and difficult question, but we have to answer it. Recent studies, especially publications in the last 3 or 4 years, have clearly shown that we used to say we have 2 types of pains: the nociceptive pain and neuralgic pain. More recently, now we know there is a 3rd category of pain that is called nociplastic pain. Now, in the category of nociplastic pain, it is becoming clear that brain involvement and areas in the central nervous system plays a very important role. And these are the difficult diseases, number 1, to recognize and then to treat. And therefore, rheumatologists are now getting involved in this field of nociplastic pain or the 3rd pain syndrome. Majority of the population suffers from non-specific back pain, non-specific jaw pain, non-specific neck pain, pains in different parts of the body and muscles. And they feel that this is all musculoskeletal diseases of a serious type. Many of them they will consider as a rheumatoid or something. And this is where I think the role is that of rheumatologists to start telling the specific features of this category of pain, the inconsistency, the variability, the association with sleeplessness and disturbed sleep, the association with different type of symptoms that include inflammatory bowel disease and irritable bladder and jaw pains and migraines and things of that sort. So my simple answer is that this is an evolving area. We didn't know quite some disturbance somewhere. Anyway, we didn't know how to classify them. and many of it was used to be called fibromyalgia. But now we know we can give it the name of the third pain or the nociplastic pain, and there are now categories and definitions of how to diagnose them. In simple, if such a patient comes, I think we have to go in great detail with their personal history, with their social history, their interpersonal relationship with other members of the family, and interrelationships during their working hours, their bosses, their colleagues, and that will bring out many of the issues which may be at the root of this third pain, so-called nociplastic pain, and which generally we used to call non-specific fibromyalgia and things of that sort. Once we are sure that we have excluded the really severe systemic immunoinflammatory diseases by simple tests like a CRP, a thyroid test, a ESR test, and a general CBC, including hemoglobin, and being sure that there are no other systemic severe diseases in the other organs of the body, then we sit with the patient, go through in detail with discussions of their interpersonal relationship in-house, outside house, in community, at their workplace. And once this is done, then we have to ensure that we have a team, because this is never treated by a single doctor. It needs a physiotherapist, an occupational therapist, a pain specialist, a neurologist, and the whole team led by a rheumatologist who understands this category of pain. And once we give it a name, it's a very important point. The 3 series of Lancet articles published about 6 months ago, they mentioned that once you have a name for it, half of the problem is solved. But before giving it a name, you must ensure that you are giving the name to a right disease. And you are not missing things like hypothyroidism, which must be excluded before we say you have the third category of nociplastic pain. Once it is done, then we have several categories of drugs, which I'm not going to talk in detail, and they are available to us also. And must say that in alternative systems, and now they are being incorporated in modern medicine also, we have opioids and cannabinoids. They can be misused widely. And countries like USA are suffering because it has not been regulated. But I strongly believe that if we scientifically approach some of these agents and conduct proper controlled trials on them, we may have something to offer for the patients who truly belong to the field of third pain. That's my simple advice and the way I look at it. I'm sure Dr. Handa also knows about it, and probably he has much more to talk about it.
Thank you, sir. I'll now have my second question, which has come from Dr. Jitendra Bhandari. The question is to Dr. Beatrice. What are the conditions that should not be missed by general practice physician in primary care if you're suspecting any rheumatological condition or disease in primary care center? Dr. Bineet, can we have your thoughts?
I was still lost in thoughts, words of Professor Malviya, Professor of Professors. I think sir has beautifully addressed the most general questions that would come to anybody's mind when we talk about the rheumatology for primary care physicians. Regarding this question, this is just a reflection of what once they used to teach us, and the fact still remains same over the past decade or more so. If you think you're treating a case of inflammatory arthritis or in any case of pain, always remember a few symptoms of red flag or arthritis. As Professor Malviya used to teach us with red flag signs and green flag signs, any features of inflammatory diseases, and even Professor Danda showed in his slide the tuna fish acronym which he had showed. So if there are features of or severe disease, if there are red flag signs, then I don't think you should ignore those, and you should continue to pursue the evaluation for a more definitive disease. It will be a long, exhaustive list to answer a specific disease that should not be missed by a general practitioner. But in a syndromic approach, if you are treating a patient with pain, just determining if the pain is degenerative or inflammatory, it would be the first step. Just for summary, if the patient has pain that is worse with rest, relieved with activity, with or the other way around, if it has a typical anatomical distribution of inflammatory distribution of joints, if there is significant morning stiffness, if there are those signs of inflammatory arthritis, you should then pursue further evaluation based on the distribution, whether a small joint, large joint, symmetric, asymmetric, age, progression. Gradually go on exploring. And even pertaining to the previous question, if the most of the rheumatological diagnoses are clinical, so based on the clinical scenario, currently I'm in one of the outreach areas of Nepal, where we do not have all the facilities that actually a rheumatologist should have available in hand. So if you do not have proper imaging, do not have a PCR for HLA or a proper appropriate serological test, you still can determine most of the symptoms and the possible diagnosis by the clinical examination and history, and get a basic investigations that are available everywhere to screen for inflammation. So once you have determined that the case is inflammatory disease or a secondary symptoms secondary to some kind of neoplasm or malignancy, then you should not be missing that. And there is a thing about steroids that is being rampantly misused, especially in outreach areas of Nepal. And I do not think it is misused because someone wants to misuse it. It is being misused because once the patient gets the medicine and feels the benefit, they do not feel the need for taking some other medication. So a proper counseling of the patient, a restriction of steroidal drugs, that should be the culture in our periphery also. So in summary, if you are working in a peripheral area with no facilities, or you are seeing all kinds of aches and pains in patients with all kind of musculoskeletal symptoms, the summary would be to identify the red flag signs. If you have the red flag signs, you have to go ahead with pursuing whether it's a secondary cause or an inflammatory disease based on clinical symptoms and basic tests available. And I would say a very less proportion of patients need to be referred to the center for a detailed examination. So instead of pointing out the diseases, I would say if you find it's an inflammatory disease with red flag signs, you should not be missing it.
Thank you, Dr. Vineet. My next question is again to Professor Malviya, sir. The question is from Dr. Vivek Gupta Mohali. What are the indications of steroids and how long they can be used in rheumatoid arthritis?
It's one of the oldest questions and probably one of the most important ones, and should be answered very straightforwardly. There are certain diseases where we have to give steroids, but those are very highly specialized areas and should be done by a trained rheumatologist who is dealing with severe diseases. And I'm not going to really discuss those diseases where steroids are a must. In the majority of the cases, if there is an urge on the part of the doctor to start corticosteroids, a few questions should be asked. Why am I starting steroids? Can I have an alternative to steroids rather than to start steroid? If I'm starting, how long I'm going to give it? Then, if I'm giving it, when am I going to stop steroids? And once we stop it and the patient says that I'm again feeling the symptoms, what am I going to do? If a person asks these 3 or 4 questions before starting steroids, I think the person will be hesitant in starting steroids. And there are very clear-cut areas where steroids can be given, and they are almost always by a specialist rheumatologist. One of them is to give intra-articular steroids in an acutely inflamed joint and give a depot preparation of steroids, which will remain in the joint and not become systemic. So least side effects, and with wonderful local effect and immediate relief within a few hours. That is an absolute indication, but then the person has to be sure that she is not dealing with a patient with infection. That has to be ensured. You have to be sure this is an inflammatory condition which is affecting 1, 2, or 3 joints, or 4, maximum 5, and you can inject these joints. That is an absolute indication. The second is the patient is a very ill patient, has multiple joints, low-grade fever, acute problem of pain and due to inflammation, and you want to control it as soon as possible. Then instead of putting them on daily oral steroid, which the patient will learn to carry in their pockets and keep on swallowing it without doctor's advice or guidance, the patient will be in trouble, and therefore try to give them parenteral therapy, either intramuscular, or admit them overnight and give them intravenous pulse therapy, which is much safer in certain this kind of acute inflammatory conditions. Besides that, giving daily oral cortisone, I think, should be left entirely to a specialist, to a rheumatologist who knows the diseases where it needs to be given. This advice I will give to general practitioners who are in the field and will like to learn primary care rheumatology. Gout may be one of the rarest of rare conditions where if there are severe contraindications to colchicine or non-steroidal anti-inflammatory drug, a short course of 2 or 3 days, maximum 5 days as per Lancet, small dose oral corticosteroids can be given if the diagnosis is certain. That is my advice and message to those who want to know about steroids. Never give a steroid without making a definitive diagnosis, and always try to answer yourself, when are you going to stop it? And then what happens to the patient after stopping the corticosteroids? How are you going to follow this patient's problem once the steroid has been stopped?
Thank you. We have already exceeded our time, but we'll take the last question from Dr. Smita Sinha from Rishikesh. And her question is how to screen children with rheumatic diseases at primary health centers. The question is to Dr. Debashish Tarna.
You have given me the most difficult question because I don't treat children anymore. I started the pediatric rheumatology clinic in Vellore, and I identified a very able successor. He was trained in Toronto. He came back and started, and it's all up to him. I refer everything to him below up to the age of 18, and that's always safe. But anyway, I will say with whatever I would like to say. Yes, at the primary care level, diagnosing a child with rheumatic disease is not all that important to label it exactly what kind of arthritis it is. I would rather say one thing which I have learned over the last many years, and now in the last few months of my mission visits in the interior tribal areas of India, I have seen that whole lot of children have been unnecessarily getting Penidior injection. Their diagnostic label of rheumatic fever is based on a fever and an ASO titer elevation and some joint pain. Commonest cause of joint pain in children and growing age is the growing pain, which is because of osteoblastic activity in the long bone ends. And it just doesn't need treatment, reassurance, or even sometime maybe vitamin D and calcium. On the other hand, you also have at times serious problems, as I have shown you, red flags like leukemias when there is a out of proportion pain, systemic features like fever, some pallor, all those things, but it's not easy to diagnose that. On the other hand, in children, almost all the arthritis are classified as JIA as one of the 7 different types. So I would say that it's probably more important not to label when you do not have the adequate evidence. ASO titer just calls it, I can call it ASO-itis rather than rheumatic fever. It's just like rheumatoid factoritis labeled as rheumatoid arthritis in many patients. Because anybody with sore throat, all of us attending this meeting, if we have sore throat, half of us will have ASO titer elevated. It doesn't make us in any way fulfilling the Jones criteria. So I have one job I have done is, instead of treating these children, I have stopped treatment for many of these children. So I think that is one thing. Second thing is, some of the things in children, I would like to say that children do not malinger. Children cannot bluff or malinger. So if children say there is a pain, there is something. Even if it is not rheumatic, if there is not anything, there is something. They don't do it for school phobia, or they don't do it for any behavioral problem. So it needs to be addressed, and as I have told, the most important thing is to rule out hematological malignancy. Other than that, the connective tissue diseases in children may or may not have often telltale features, but there will be, like lupus and other severe conditions, there will be something like they'll have edema, they'll have proteinuria, etc., or skin changes, etc. On the other hand, if it is JIA, if it is oligoarticular type, if it is enthesitis related arthritis, possibly you can diagnose them in the periphery, because we do not need a big list of investigations. We just need, Professor Malviya said, a CRP and an X-ray, which is available everywhere. I was surprised to see even in the deep interior areas, CRP is available in most places. Even rheumatoid factor and CCP was available in the most interior tribal areas, who has to go 6 hours to a district hospital. So it's not too bad now we are living in this India. So I would say that you can still do a lot of things. Do not overdiagnose anything. Other thing in children, I would like to say, I have stopped treatment methotrexate for several children who are getting methotrexate for progressive pseudo-rheumatoid arthritis. This is a condition will look like a typical JIA with all the joints of PIP, DIP swollen, and they will be having a whole lot of joints swollen, but child has no pain at all. So examining very carefully, you find there's no this thing CRP, everything is normal. Then you go back to that, and you find this progressive pseudo-rheumatoid arthritis. The X-rays will show some changes. The lumbar spine X-ray will show spondyloepiphyseal dysplasia, the elongated vertebra. So what is the treatment? Stop the treatment. So that is the treatment I have done for these people and reassured the parents. The other thing, I was surprised to see, after probably 20 years, I saw in one of the tribal areas in Bisam Katak, a small child came to me whose one finger was looking like a boutonniere, like type of deformity. And the child was getting methotrexate for a long time. But I asked the history since when. He said from birth. I just couldn't believe a child can have from birth this kind of this thing. So as Dr. Walsh said, he's got a conflict of interest. I have a conflict of interest with a geneticist who is my wife. So I called her up and she said this is nothing but congenital camptodactyly. So I stopped the methotrexate, and I hope the parents and children will be happy because it doesn't require anything. They may have some associated things. We are going to do a genome this exome sequencing to find out if there is any other syndrome associated with it. But what I am trying to say that most children you can manage at the periphery with the available investigations, and probably doing the minimum is always better than overdoing something with the child.
Thank you so much. I think it was a very interesting discussion, and it's not possible for us to take all the questions. So I think if at all you have more questions, you can write to us, but it is time for us to conclude this. Before we conclude, I'd like to thank all our senior rheumatologists who have joined. Thank you so much, Professor Malviya, sir, Dr. Debashish Danda, Dr. Binit Vaidya. Special thanks to all our faculty and to my colleague, Dr. Gaurav Singh, who has contributed again and helped us in bringing us this course for every one of you. And from here, I now hand it over to Dr. Prashant Nag. He's representing Tata 1mg. And over to you for closing remarks.
Good afternoon, everyone. Thank you, Dr. Anna Malviya, for this wonderful session. It is really great and enlightening to be a part of this knowledge platform with stalwarts of rheumatology. Anyone who is practicing medicine in this part of the world knows the contribution of both of you in the field of rheumatology. So a bit about me and my organization. I'm Dr. Prashant Nag, pathologist by qualification, and I look after the diagnostic division of Tata 1mg. 1mg started with a simple vision of making healthcare affordable, accessible, and understandable. Our vision is to build an integrated healthcare experience for patients, and diagnostics is a critical pillar of this ecosystem. So we are working on that. We have always believed the diagnostic experience can be massively improved, and we started by addressing the first step in the journey, that of home sample collection. Over the past few years, we have built our own capabilities across the value chain and contributing our bit to diagnostics science by bringing quality home collection services with minimal pre-analytical error. All those who are working in the side of diagnostics, they understand that pre-analytical error is a very important thing, and home collections, we need to take care a lot about that. Today, we operate a fleet of over 800 trained and fully vaccinated phlebotomists for home sample collections covering more than 30 cities. On the lab front also, we have built a nationwide network of state-of-art diagnostic labs operated by a team of experienced pathologists, microbiologists, biochemists, and molecular scientists. Our businesses and processes are supported by industry-leading technologies from sample collection to reporting. Earlier this year, we marked an important milestone of opening our first national reference lab in Delhi, placing us amongst the first few diagnostic chains in the country having our own reference lab. Today, on the occasion of Doctors' Day, on behalf of Tata 1mg, I would like to express my deepest gratitude to our fraternity of doctors and future doctors present here, and thank you for your service towards humanity. Today, we would like you to take care of yourself, and we invite you to avail a free full body checkup from Tata 1mg Labs. Post this session, there will be an email post on webinar for you to share your details, and our team will reach out to you to book a hassle-free and safe home sample collection. Thank you once again for all your professional care and compassionate attention towards patients.
Can I request Dr. Kaul to give me 20 seconds?
Sure, sir. Sure, it will be our pleasure.
Especially because I saw Dr. Prashant Nag is from AIMS, Pathology Department. When Dr. Ramlingaswamy was the head of the department, that's when I was there, and I used to spend a lot of time in pathology. Dr. Nag, you are heading a place where they are doing tests. My request, sincere request as a rheumatologist, please, these so-called packages, if you can ensure that you don't do that, because then you get a uric acid being done in a woman in reproductive age and a child getting uric acid done, and a person with back pain getting anti-nuclear antibody and ENA testing done and DNA antibodies. Please, we are getting so upset. Yesterday I decided enough is enough and I'm going to give up. I will go to jungle and start praying to God, because I can't continue to explain the patient that these tests have nothing to do with any disease that you have. You have simple non-specific back pain or toothache or something. ANA is positive in 40%. Please, for God's sake, don't do these packages. And patients are so happy showing me phosphate and sodium is slightly up or down. What are we doing? Please be careful. Help us clinicians, because half the time is now being spent in this kind of nonsense explanation to a poor patient. They don't understand and they are questioning us on things which have no relevance in clinical medicine.
I understand, sir. I definitely understand that. And it's just that this is more of a commoditization of the whole thing. But at times, there are places where this preventive checkups have their own role. So, but again, now people are bundling up their tests for their clinical needs and coming up with to all clinicians. And this is something which I face many times, that these packages are doing more of anxiety part than to good to patients at times. So definitely, sir,
I have started telling patients that any test that is done beyond the test that I have requested, I will not answer. I will not respond to that.
I got it, sir.
Thank you. Thank you so much. Thank you, Dr. Malviya, and thank you, Dr. Prashant Nag, for announcing this package. And thank you to all our panelists for such an engaging and interesting session and taking time out of your busy schedule. Thank you to all our viewers for attending this session. As you know, we've officially launched the course now. The batches are starting in July 2022. We are accepting the applications. The URL or the website is mentioned on your screen. It is educationindia.bmj.com. You can check out more details about this. We will be emailing you more details about the course. I also request you all to please spare only 30 seconds. There are very few questions in the feedback form which you can see on your screen. It will help us to realize and understand our areas of improvement and help us to deliver better webinars in the future. As mentioned, all the participants will receive the discount coupons for the course enrollment and also the free health checkup packages from the Tata. The information will be provided through the email. So now we formally close today's session. We apologize for extending it more than the time we had to, but I'm sure you all must have found it very useful. And thank you so much. Thank you, everyone.
Thank you. Bye-bye, everyone.
Thank you. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir, for
Debashish.
joining. Thank you, sir. Thank you, Dr. Simi.